Good afternoon, ladies and gentlemen, esteemed colleagues. Good morning, good afternoon, and perhaps even good evening. The International Health Committee welcomes you to today's webinar entitled Intensive Care, All Ado About Little, Appropriateness of Care, an Impossible Venture. We're very happy for you to join us, and please feel free to ask questions in the chat, which we will monitor and try to get back to you in the course of the webinar as soon as possible. I thank the International Health Committee for setting up this webinar, and I'm very happy to be joined by esteemed colleagues and would like to do a short introduction round, starting with Dr. Ann Generich from Seattle, United States. Ann.
Thanks so much, Andre. Yes, my name is Ann Generich. I'm an associate professor of medicine at the University of Washington. I primarily practice medical and neurocritical care at our Level 1 Trauma Center in Seattle.
Thank you very much, Ann. We'll continue with Jacqueline Kagima from Nairobi, Kenya.
Hello, everybody. I am Jacqueline Wanjiko Kagima from Nairobi, Kenya. I am a pulmonologist and a critical care specialist here at the Kenyatta National Hospital in Nairobi.
Thank you very much. Neil, next please, from Toronto, Canada.
Hi, everyone. Neil Adhikari. I'm an intensivist at Sunnybrook Hospital and University of Toronto, and pleased to be here.
Thank you. I'm Andre Michelson. I'm an anesthetist and intensivist in Constance General Hospital, which is located in the southwest of Germany, right towards the border with Switzerland. Ladies and gentlemen, esteemed colleagues, today we're not talking about milligrams or milliliters or any specific drug that we might choose in intensive care. Rather, we would like to discuss concepts, especially in light of the very different locations and health systems that the four of us and you all practice in. And the webinar is subtitled with Appropriateness of Care. Is that possible or perhaps impossible? Appropriateness, supposedly having been coined by the German philosopher Immanuel Kant, appropriateness is described as the nature of a measure to encompass no more or less than the matter requires. No more or less. And as an anesthetist, I'm very fond of simple tables or simple procedures, if you will. And so we thought to present you with this fourfold table that basically says that care is only appropriate when it is both medically indicated and consented to by the patient or the legal representative. In all other combinations you see, care would not be appropriate. And that having been said, which is a very general statement, obviously, that having been said, one could almost immediately come to an end of this webinar. And by the way, that's the statue in the harbor of Constance city. However, though, we would not have done a webinar for 5 minutes. And I'd like to continue with this gentleman, who most of you might know as Inspector Colombo, who at the very end, when the suspect already thought that the trouble was over, usually comes and Anne or Neil or Jackie, what did Inspector Columbo then said when he was just turning around to leave the door? Any idea? And what did he say?
I think he always came back to there was just one more thing that he wanted to talk about.
Yeah, thank you. I have just one more question. There's just one more thing. Because if you were to go back to what we think is appropriate, then there's at least two things to be clarified. What is medically indicated? And what then, or when, is a measure consented to? And that may vary from country to country, from culture to culture, and from legal system to legal system. And that's why probably there's not really a universal answer. So the first question we have to discuss with all of you, and please feel free to make yourself heard in the chat. What then is an indication? What then is an indication? And you might think that that's very simple. We do this every day, many times a day. But sometimes setting an indication is not that simple at all. Very simply said, an indication is a reasoned decision for a particular, in our case, medical action. Well, there's two words important here. That is reasoned and decision. Reason usually meaning based on evidence that we have. And decision usually means that if you have several options, someone must decide which option to take. And my colleague Neitzke from Germany said that making indication is a very important moment for the exertion of clinical ethics. Why would that be? We're going into a case very soon, colleagues. Let me just try to explain one more thing as to the indication. Indications, if you look at it more closely, has three parts. Because to make an indication, we need to understand what the problem is of the patient. So it's best to have a diagnosis. Because if we don't really know what we're treating, it's very difficult to make a decision to treat. Second, the indication must relate to an attainable therapeutic goal that is agreed by the patient. Because if we do not get the patient into the equation, if you will, then we can have the best idea medically speaking, but we may not even be allowed to do it. And third, there must be a certain probability that what we're going to suggest as a treatment really can attain or help attain the desired goal. And again, we do not do this with every single step that we have to decide in terms of treatment, but for very important medical or surgical treatments, we need to understand how difficult indications can be. So let us go, please, into a case report, day one. And please, colleagues, this is not about, again, the acute frequency of the heart or the acute or the true frequency of breathing. This is more to give you all a picture of a 90-year-old patient from South European descent, known for COPD and insulin-dependent diabetes, and he's a smoker. And he's admitted to the ICU for severe dyspnea. He's tachypneic, tachycardic, has an angina, however, the ECG is inconspicuous. The wife, who is the legal representative, conform to the legal requirements in your country. The wife tells us that her husband fell about 7 days prior to the admission, but there were no visible major trauma sequelae. His GP prescribed antibiotics, which the gentleman did not take. Well, Jackie, that gentleman came to you. Is that something that you would say is usual even in Kenya, or would you say this is completely out of the picture of patients?
I would say this is very usual in my setting. Older patient who has several comorbidities coming with issues of having tachypnea, tachycardia, and angina. So we see such patients in my setting.
Thank you. And I would think, Neil, is that something very rare where you practice?
Older patients with traumatic injuries or a story that's consistent with trauma is unfortunately a very common type of presentation.
Thank you, Neil. And I would hold that then this is also a relatively common scenario in Washington State.
Yep, every day.
Yeah, folks, patients get older, and the number of patients above 65 is increasing, treated in intensive care, and even the number of patients older than 80. Well, okay, let's see how the case evolves. And shortly after the admission, unfortunately, the gentleman has a problem of airway patency and breathing. And by your assessment, the patient now needs ventilatory support. However, he cannot consent himself any longer because he's now incapacitated. The wife reports that the husband is fond of life and has always been un lottatore, which means a warrior. Wife goes to the female physician, says, nurse. To the female physician, she says, nurse, you will certainly do everything. Come on, get the doctor now. Meaning now, right away. The daughter, however, who has just arrived, said, well, mom, they did not want to be connected to machines. And throughout the webinar, we will ask for a pause for ponder, a slide that will come up again. And we're asking for the therapeutic goal, the indication, and the action to be taken. So, Jackie, what do you think the therapeutic goal is in this 69-year-old man?
I think the therapeutic goal is to stabilize the patient hemodynamically. He's having tachypnea, he's having tachycardia, he's having dyspnea. You want to basically help this patient be able to breathe without difficulty. And that's our goal, to stabilize the patient.
So you would say that the situation of the gentleman is life-threatening, saying that if we don't do anything relatively quickly, then the patient might come to pass away. However, then we heard the wife and we heard the daughter, and obviously they're not agreeing. So then what? Neil, you're going to start negotiating then between the wife and the daughter?
Well, unfortunately, this is a very time-sensitive condition now in this patient with imminent respiratory arrest, perhaps, and medically is, urgent indication for intubation. So unless these negotiations are able to come to a conclusion extremely quickly with agreement among the family members, I think that's probably not going to be a fruitful path.
Thank you. That was nicely said. In a very time-sensitive situation, one might not necessarily get the two ladies to agree. So, well, I've heard that in the United States, the patient has a lot to say, maybe even more than in the rest of the world, or at least in Europe. So, Anne, you're going to talk to the wife and the daughter, or are you going to go intubate the patient?
Yeah, I think that conversation is we're gonna have to put a pin in that conversation until we get the patient stabilized. Trying to have those conversations in the heat of the moment when somebody's actively deteriorating is just not feasible. And it's easier on our end to intubate the patient and get him situated and then have the conversation than try to deal with what happens if the patient dies while you're trying to have what can be a complex conversation. So we would just do the ABCs, right? Get him situated, and then we would say, let's all take a deep breath and sit down and talk about this after he's stabilized.
Thank you very much. I cannot but agree, and I'm hearing among the panelists that in that situation of the immediate need to help the patient and stabilize, especially now his ventilatory and cardiac problem, we would not necessarily have a long discussion. We would go ahead and intubate, ventilate the patient. For the younger colleagues, calling the attending, well, the four of us are all attendings. That's why for us, that's probably not a good solution. But for the younger colleagues, please make sure that the attending that you call is not an hour away, because this problem of this gentleman at this point in time needs immediate action. And if really later turned out that that was not the correct action, a tube can always be taken out. Simply speaking, again, I'm an anesthetist. So, all right. Neil, I don't see anything in the chat. Neil, is there anything in the chat?
Not as of yet.
Okay. So I would like to think that that is relatively agreed upon. We save the patient's life in this first very difficult moment. Now, you can think that the story goes on, otherwise the webinar would be over. So 5 days later, the patient is still, which means the whole time mechanically ventilated, treated for multiple rib fractures and pulmonary contusion, and severe pneumonia and sepsis. So the treating team suggests to insert a pleural drainage for pleural effusion. The wife reiterates that her husband is still fond of life and a gran lottatore, which means a great warrior. She has consulted with her brother-in-law, and she does not consent to the procedure, which means putting a pleural drainage for pleural effusion, not for tension pneumothorax. So we'll pause again. May I call upon you, Neil, to maybe ponder about the therapeutic goal or the indication of what we are suggesting?
Well, I think from a medical perspective, we have a patient with rib fractures and maybe even a hemothorax who's on the ventilator for 5 days, and we think that the pleural effusion is large enough that it's affecting the patient's mechanics. So there's a very clear indication to drain it in a patient who's not been easily weaned. And so that would be the therapeutic goal and the indication. But we're in a situation where it appears that patient's still alive and being ventilated. So the family has indicated consent to proceed, and yet the substitute decision maker isn't agreeing to a procedure that we're recommending medically that might help the patient to get better. So that's a bit of a difficult situation.
That is a difficult situation. Or would you just go ahead? Anyone in the audience perhaps telling us that, why that discussion? Patient needs the drain, so go ahead. I, in Germany, have to say that might be not legal, because this is a measure that also might carry complications. So we might do harm, especially if we go against the will of the legal representative. So do we call the brother-in-law and try to persuade him to approve the procedure? And I'm calling on you again because, in America, as I said, the loved ones have big crowds behind them and they have a say.
Yeah, no, it comes up a lot that people want to, there's a primary decision maker who legally is a decision maker, but they want to involve many family members and come to a consensus. And we encourage that. At the end of the day, though, the decision-making authority falls on the legal next of kin or the designated power of attorney. In this case, is the wife. I don't know that there'd be a lot of utility in trying to circumvent the wife and talk to the brother-in-law. And in fact, trying to do that, to talk to one family member over another, is a great way to de-establish any rapport you've built and also create more conflict within a family. I think that this discordance between saying someone is a fighter and they want everything done and then declining recommended procedures is common. This was very common during the COVID pandemic, that people would want aggressive interventions, but then they would decline intubation and mechanical ventilation because of their concerns about what the ventilator would do to their lungs. And so it just required a lot of sit-down meetings and conferences about sort of aligning what our therapeutic plan is with their goals. And generally, we could come to a consensus in that way. So at this point, I think you just have to focus on the patient's wife and what trying to help all get on the same page about what we're doing here and what's the patient, primarily what the patient would want in this situation.
Thank you very much. So I think it's very true. If we try play out one family member to another family member or members, that might cause conflict that we really don't need for the patient's sake. Plus, legally speaking, also in most European systems, I would say the wife has the decisional power. We have to hear the others, but in the end, it's in this case the wife to give consent in the patient's best interest or not. There's still the discrepancy of someone wanting everything being done, but then neglecting to one portion or puzzle part of what needs to be done. Well, how about this family meeting with the wife? I heard that might be a reasonable way to go at that moment. Jackie, how about that? You're meeting with the wife.
Yes, I think meeting with the wife is a reasonable option because the wife is basically the legal representative and explaining the importance of the procedure. But Andre, that I just need to bring up an aspect within the setting that I work in. We have African culture, which sometimes allows polygamy. So sometimes you have this kind of patient, but you have several wives. And this is probably a lot more in our setting. A lot of patients don't identify or don't have advance directives. So you have several wives, you have a patient who needs a certain procedure, and we don't have a identified legal representative. So sometimes we actually are in a problem because we now have to talk to all the wives, maybe 2, 3 sometimes, and all of them have probably differences in opinions, and so it sometimes drags the process, but eventually we end up having consensus. And if we fail to get a consensus sometimes, then we choose what's best for the patient. Yeah.
So you're not going by majority, right? 4 wives for and 3 wives against, that makes the 4 wives win.
We a lot of times we do that actually. So we have the majority say like this, so we go, we go that way, yeah.
Thank you very much. This is for most of us, I would say, with a Western background, relatively uncommon, to put it at least. But this is the beauty of that session, may I say, of that webinar. Also, we talked about that earlier, that we learn that there's not one single optimal way for every patient in every place of this world. So we think we best talk to the family and specifically to the wife and try to explain why putting the drainage in is part of please do everything. or at this time, do what is technically sensible and possible. Well,
Can I just make a couple of
oh,
points?
sorry, yes, Neil, please go ahead.
From the chat. One is an important point of as part of the meeting with the patient's wife, assuming that she is in fact the substitute decision maker, is to make sure that she understands her role, which is to represent prior capably expressed wishes of the husband, if such wishes exist, and if not, to reflect on his values and take into account best interests. That may be codified to varying degrees under legal provisions, but I think the point was made in the chat to make sure that the job of the substitute decision maker is to reflect what the patient would want in the situation. And then another attendee has made the point that reflecting on practice in India, that there's major cost constraints, and sometimes these decisions may be driven by financial considerations. In other words, families may not be able to afford these recommended procedures, particularly in private hospitals. And that can also enter into decision making in the way it presumably does not in public hospitals and highly resourced settings.
Thank you very much, Neil. I think both attendees touched on very important points. The second, maybe first. What I'm hearing is, if I'm paraphrasing this correctly, that sometimes decisions are based on the financial possibilities of the patient and or their families, which then might probably lead to under treatment, because sometimes treatment options are not being taken just because they cannot be paid for. And we have to be, I think, very happy that in many countries that does not, or at least not to that regard, play a role. However, we should also understand that in one of the biggest countries of the world, there is no general health insurance. This is a country that spends about more than 10% of its gross national product, like Germany, but I would say in that regard, there's a big difference between this big country and my country. I'm not trying to explain that, and this is just how it is at the moment. The first point being, as to the chat, that it seems to be difficult for family members, not all and not always, but often, to discern between the values of the patient whom they're representing and their own values or needs. How would one make sure, as a potential future patient, that one's own wishes are being followed? Is there means to do that? And
I think, at least for us, the primary way that we do that in this country is through advance directives, or they're called different things in different states, but in Washington state, it's called a POLST form, a physician order for life-sustaining treatments, where you can fill it out with your primary care doctor, or any doctor really, or advanced practice provider, and have that on your refrigerator. So when the medics come to your house, they can look at it and see what types of treatments you would or would not be interested in. Those things can be helpful, but the reality is that even if you have a living will that states what you want, they're often vague boilerplate legalese, and they don't necessarily direct care very specifically. So it always comes back to us as the clinicians to sit down with family members and help navigate this with them. I usually start off these meetings with not talking about the nuances of the medical care, the ventilator, the pleural effusion, and start the conversation. Let's talk about your husband, John. Tell me about who he is, what's important to him. And that way, even if people have never had an explicit conversation about end-of-life care or critical care, you can get a sense of who the patient is and whether or not a life, especially in the neurocritical care setting, a life dictated by significant disability would be something that they would want to pursue with long-term life support or dialysis and things like that.
Thank you very much. And you said something important. One has to get to know the patient. So what is your husband, your mother as a person before the acute illness? And what would he or she want? Well, and is that time paid? I mean, you sit down with patients, if I understand that, several times, obviously. Do you get any extra pay for that?
I don't personally, but the hospital does. You know, of course, the way that our system works, it all goes into a large coffer and then it's given to us because I work in an academic setting, so we're salaried. I don't get paid more the more of these conversations I have, but we certainly did get reimbursed for them because we bill them as critical care time. The time spent with families in discussing medical treatment and decision making can be billed for because it can be, like you said, quite time consuming. I mean, just this last week, I probably honestly spent more time talking with families than I did with, you know, providing actual bedside care in terms of like procedures and things like that.
Thank you. Neil, do you get or does your hospital get extra money for talks?
It is provided that a certain amount of time is spent with the family, that time is reimbursed. It's relatively modest, but there's an acknowledgement that there's something additional involved compared to the daily rate for providing critical care. I wanted to bring up one other comment in the chat, which is the situation where the substitute decision maker or healthcare proxy, depending on the term that's used, doesn't follow what's written in the advance directive. And you know, sometimes it's because the advance directive can't possibly anticipate every possible nuance, and so they can be helpful for things like, you know, not for CPR if it's put on the refrigerator and then the paramedics won't provide that. But for maybe more complex decisions like a chest tube or maybe even a thoracentesis, as someone else in the chat suggested for this patient, they may not be so specific. But sometimes it does become clear that that the substitute decision maker isn't following what's being written down, acknowledging that what's written down is sometimes vague. And then in some jurisdictions, there are mechanisms where there's an adjudication process essentially that's independent of the clinicians and the families to decide whether the substitute decision maker is acting according to their legal obligations. That ends up being a very long and drawn out process, and it's far better to try to negotiate these as everyone has mentioned.
Thank you for that information. That is even more time. And sometimes a long time. We would say, I think, in my system, that the written patient will would prevail over someone's action, but that may be discussable, so to speak. I was going to ask Jackie. Jackie, are you paid extra if you talk to patients or family members?
I wish we were. Talking to family members is considered part of the normal duties and not any. I'm actually seeing from the chat that can be considered a procedure in my setting. It's part of your work, normal work. So
see, we've tried in Germany to get an extra cipher. We are built, or it is not we, but it is built. Treatment is built by specific ciphers or codes. But for those talks and negotiations with the family, there is no extra code. It's like for you, Jackie, this is considered normal care. However, we do know that 2 hours of talking to the patient may save 10 days of intensive care money, so to speak. Shall we go on? I think we'll move on and see what further develops in the case. 5 days later, the patient is still mechanically ventilated and treated now for septic shock, including kidney failure. And the invasiveness of the ventilation needs to be increased continuously. The wife reiterates that the husband is nonetheless fond of life, and he is un lottatore miraculoso, which means a miraculous warrior. Now she has consulted with her lawyer and she demands transfer for lung transplantation. Therapeutic goal, indication, and action. Well, well, well. I think if I say that to Jackie, she will have a relatively simple answer. Is that so, Jackie?
Well, we do have a therapeutic goal and an indication. The patient is in septic shock. So we are bound to treat the sepsis, you know, and to help the patient. So there is definitely a therapeutic goal. We don't have transplant services in my country, and I'll just specifically talk about my country because Africa is, we have many countries. So transplant is not an option. So if the wife insists on transfer to transplant services, then it would be probably a transfer from the country to go to a more, maybe a higher income country where they can get such services.
Thank you. So for that, for all practical purposes, the answer is clear. No, because there is no such thing, at least not for, let's say, the majority of the patients that are being treated, except maybe a very small group who can then afford the transport as an intensive care patient to another place. The question is still, is there an indication for lung transplant in a patient? So in Canada, Neil, what do you think? Is that patient a patient for a lung transplant, an acute lung transplant?
Yeah, I don't personally look after transplant patients, but having interacted with the transplant center, I can say categorically that this patient would not be a candidate for lung transplantation in their current state. And but yet we may still have to call the lung transplant physicians in order to have a formal opinion and to document that and to reassure the patient's wife that we looked into it. But then I think the priority would be to have a family meeting, and a couple of comments in the chat are supportive of that approach as well.
That is great to hear. I mean, for those somewhat younger in the audience, some people always say, well, this patient is not going to die in my shift. So I just carry the patient over the shift and wait until my shift is over and then, trouble for the next. In principle, on the one hand, it is understood that people would not want to take difficult decisions. On the other hand, if we always wait until the shift is over, we never learn to take difficult decisions. A question back to Jackie. Jackie, would you not wish that finally you would open up the transplant department in your country and really go ahead? How about that? I mean, it's technically available in the world. Should it not be available everywhere?
I think when you talk about my setting, we are struggling with basics. So I think when you're struggling with medication, availability of certain medications, when you're struggling with bed space, simple things as just an ICU bed space, talking transplant is good, but might it be overreaching? Possibly. However, it's always good to have progress. And I think there are some hospitals that are really, the private hospitals that insurances basically cover the costs, could think about it. But even though I doubt such a patient would be a patient they would want to take for transplant in a resource limited setting.
Thank you very much. I think the underlying question here is, do we always need to do or provide in every patient what in principle is technically possible? And I think that the panelists, the four of us, agree that no, we should not, just because something is available in principle, use it on every patient. Rather, we should make an individual medical indication. And then if the treatment measure is available, wonderful. But if it's not, for the circumstances that we have to treat under, we cannot suddenly order the transplant team and the transplant equipment, also not to Konstanz Hospital, maybe except renal transplantation. So again, this today is not about always do all, but it's more about thinking of what we should be doing if available. Neil, is there any thoughts from the chat or questions in the chat at that point?
No, I think there's agreement on this point.
Great. Thank you very much. Please feel free, again, I say this, to make yourself heard or read, so to speak, in the chat, and we'll go on with this case. And it's about a slide in between, so to speak, about a patient's wishes and values. We think that it is important to elucidate the patient's wishes and values as soon as reasonable. That does not mean during the resuscitation, but it also does not mean 20 days later when everything else has failed. We in Germany have a rule or a quality indicator that says within the first 3 days. Personally, I think that's too late, but at least we have a quality indicator for intensive care. It's important to understand the patient's wishes because that lets us understand what for the patient is the appropriate treatment according to their values. And at least in most of Europe, the patient's wishes, if clearly said or written down, are binding. Binding means that we cannot overrule them in principle. However, as already said, sometimes it's not so clearly written down, or the legal representative is not able to phrase it correctly, and then the trouble begins. However, and I'd like to stress that point, however, at least in our jurisdictions, the patients or the families cannot force the healthcare team to render non-indicated or non-beneficial treatments. Nicely said, nicely written down. However, does that still happen? And
I think similar probably to other nations, we cannot be forced to provide care that we don't feel like is appropriate. But it's nice it's nice sentiment in general, but it doesn't sometimes address the things that people request from us in real time. And so like the general idea is there, right? But I think this comes up for us a lot, and this is obviously related to our criteria related to brain death, is that we will determine someone has experienced death by neurologic criteria and the family doesn't agree with the concept of brain death. And so our team is left to provide care to someone who's legally dead in this country by our determinations, and that can be really distressing, especially to the nursing staff. And so I think there are situations where we are, in a sense, forced to render treatments that we don't agree with, but it always comes back to the conversation with the family. And I try not to involve our legal teams or our ethics team or our risk management teams early on, just because I don't want to create tension between myself and the family. I think we talked about this before, but most times you can come to a consensus. We all remember the cases where like things get really heated, but in general, most people are reasonable to a point, and you can find a middle ground. But I do think it's nice to think that nobody can force us to do things we don't want, but in the reality, sometimes we actually do have to provide care we don't agree with.
which, as you said, and thank you, does cause or aggravate moral distress that usually nurses are more prone to than as physicians, perhaps. I heard, Neil, that in your country there's a very clear legal underpinning of this last point we just talked about.
Yes, it's actually just in the province of Ontario, and particularly around the issue of CPR and related resuscitative measures, where there was a gray zone for a period of time where the provincial regulator held that CPR would have to be provided if the families requested it, even if the physicians didn't feel it was appropriate. But that's no longer the case. And so I think it's for any treatment that's not being offered, it's really not an issue of consent for the families or making demands because it's a treatment that's not on offer. And I think I agree with Anne that the overwhelming majority of these kinds of issues, end-of-life issues with families, are resolved over a period of time and a series of conversations quite amicably. But the ones where there's conflict certainly occupy a lot of mental space. And one of the webinar attendees has pointed out that the majority of the population, in fact, hasn't considered their own mortality and hasn't completed a proxy for end-of-life wishes. I'm not sure what the data on the proportion of the population that's completed them, but I do agree that it's not terribly common. I think we do get into this gray zone where, maybe I don't particularly want to provide a certain treatment, but one of my colleagues might think it's reasonable, right? And then what do you do? And I think there was a bit of this, maybe as a relatively recent example, early period of COVID, where there were some treatments that were relatively unstudied, and some physicians would be okay with giving them, and others would say, no, I don't think that's appropriate, or only in the context of a clinical trial. And I think those situations are harder. I think it's if a surgeon doesn't want to offer surgery or transplantation, I think it's fairly straightforward. But there are these medical treatments, which is just an injection of some medication, where I think it gets a bit more tricky.
Thank you very much, Neil. I'm hearing that in Ontario you're relatively safe, at least in terms of CPR does not have to be provided if the physicians or the treating team thinks that that's not indicated or non-beneficial. Well, Jackie, how is that in your setting?
Sorry. In my setting, I agree. We are sometimes forced to do things that are not indicated and not beneficial. And more reasons for that is for political reasons, because we have if you come to my country and in my setting, we have a spectrum of ICU care models. I don't know about the other countries, whether you have a particular system. What do I mean by this? So we have a closed system in some hospitals where the ICU experts make the decisions. And that's whatever the ICU experts say goes. And then we have some hospitals that entertain an open ICU care model. What does that mean? That the primary physician, perhaps in this patient who had COPD, that would mean the primary physician would be a pulmonologist, And in my country, not all pulmonologists it's not a must you do pulmonology and critical care. So the primary physician may not know so much about critical care and all that, but the family has trusted them over the years, And so they sometimes push for care that is not indicated and not beneficial. And when they do push for that, in an open care system, sometimes the ICU team is forced to comply, which is not really good. And this happens a lot more in patients with money, patients who they can be able to, we've got patients in my setting, fly doctors from India to do ECMO for a patient, you know, in one of the ICUs? Was it indicated? Was it beneficial? Some patients don't make it, some patients make it. So we have a spectrum, in short.
Thank you very much. This is a very interesting explanation, so that within a system as a whole, there's, so to speak, subsystems of care or subsystems of who makes decisions. And you're telling me that then the long-time trusted butcher suddenly makes the decision on baking a baguette, so to speak, which is an art. I learned to make a baguette, and I don't trust my butcher to do so. But you see that even amongst the four of us, we describe very different, or at least in part, very different settings. And therefore, this last line on the slide, this last bullet point, is a nice general point, but whether that always can be followed may very much depend on where we practice and under what directives, so to speak, we practice. Neil, is there anything on the chat on that?
Yeah, maybe just a couple of points. One, just to follow up on what Jackie said, I think webinar attendee made the point that if there's conflict among the care team, and it might just be the intensivists or it might be the ICU physicians and other physicians, clinicians that are involved, it creates confusion for the family, and it suggests that actually there's no reason not to provide the particular procedure because there's disagreement about it, about whether it's indicated. So I think that places families in a difficult situation when there isn't consensus on the best way of approaching a particular problem, and perhaps an approach there is to acknowledge this uncertainty with the family and potentially be less dogmatic about not offering something. And then someone else has made the point that sometimes the clinicians are put in a situation of having to decide on a course of treatment if there's no next of kin available, and one sometimes does run into situations where patients have traumatic injuries and they're brought in unidentified, and is really their true identity isn't known for a prolonged period of time. And at least where I work, there's a way of dealing with that in the short term. If it's an emergency treatment, the clinicians can provide it, and if it's not an emergency, then you need to get consent from public authority called the public guardian and trustee.
Thank you very much, Neil. Now let's come to the next and then last point in the course of this gentleman's problem. In the hospital, renal dialysis was implemented due to kidney failure, and the wife reiterates that the husband is nonetheless fond of life, and he is un lottatore invincibile, which means an unconquerable warrior. Finally, then, so to speak, a recently appointed attending is about to administer a new costly experimental anti-shock drug called James Bondimab. So, what do we do? Do we call the hospital chief financial officer usually 2 o'clock Sunday morning? Or do we finally side with the new attending, luckily a hero on the floor, and forget about the costs now? Or do we side with Bertolt Brecht saying, unfortunate a country that is in need for heroes? Jackie, who do you side with?
Well, I think my answer is easier. We just don't have James Bondimab.
You don't have James Bondimab. Okay.
We don't have.
All right. Simple answer. What you don't have, you can't administer. All right. Yeah. Neil.
Well, we're sometimes in a situation where a drug is available, but it's not licensed in the country because it's a relatively small country. And if you really want to give it, you have to fill out a whole bunch of paperwork. and that often doesn't work in these tight time frames. So I think even if this drug were maybe proven to have some effect on shock reversal, we would tell the family that we might try to procure it, but we didn't think that we would be unsuccessful in doing so. And it would be in our setup, it would be up to someone from the hospital to say you can't provide it because the physicians in our system aren't the financial gatekeepers really for the hospital.
So you would not break into the pharmacy at night and get that James Bondimab, would you?
If the drug existed, then it would be there would be no barrier to prescribing it. But most commonly, the situation is the drug in theory exists because it's been developed by a company, but it's not practically available. And the only way to get it is through a special access mechanism, and it'll take forever.
Well, that leads us to one of the final slides, which is about unproven or ineffective or inappropriate care. And we think that as teams, we're not required to provide non-indicated or potentially inappropriate treatments. The core sentence is that what is indicated is a medical judgment call. And other stakeholders can help us in terms of the patient's will or the patient's past, or they can say, well, I've read this and that and the other. But the authority or the responsibility, better said, the responsibility to offer treatment options and also then be available for potential complications, this is a physician's responsibility. And I'm encouraging this because in my system, which for very long held that the physician's indication was the threshold, there are some legal people who say that the patient wills must overrun or must be higher than the physician's responsibility. Time is almost over, and I'd like to conclude with 2 slides and then a final statement of my co-panelists. We think that striving for the appropriateness of care for each patient is challenging or can be challenging, yet a possible mission, and it is certainly worth all the ado. And again, the medical care is appropriate only when it's both medically indicated and consented to by the patient. And going back to our Inspector Columbo being played by Peter Falk. Peter Falk said in this wonderful movie by Wim Wenders, that's what makes me clumsy, the absence of desire, which means that if we do not, in general, have the desire to seek out the appropriate care for the patient, then we are really not overall doing a good job. May I please ask you for your final statements, at the same time being very grateful for being with me on this panel. And a final statement as to the appropriateness of care.
Yeah, I think the central theme here is what's appropriate is the term appropriate is sort of in the eye of the beholder, right? And so our job is to take our medical knowledge and align it with what the patient would have wanted and to use their proxies as their voice. And as Neil said, we almost always can get there. Sometimes it takes time, and so you have to be patient with people and remember that this is the worst time in their lives. It may be an average day for us, but we can all find a place where we find care that's appropriate for the patient.
Thank you very much, Anne. Neil.
Yeah, just to add that I think that whole process really represents the value that experienced clinicians, ICU clinicians bring to these difficult situations. And I think it's probably the most rewarding and important part of the job of our jobs is to is to bring care to patients that's aligned with their wishes, and that is appropriate.
Thank you very much, Jackie.
Just to add what they've said, I think it's a process, as we've said, and for us, every day we discuss, change of goals is accepted, you know. You can change goals depending on the patient's outcome or how the patient is faring. So we should accept to be able to work around and change our goals as long as we work with the next of kin and the patient's relatives and work with them.
Thank you very much. I think that the openness as to how the course evolves and trying to do the appropriate care with desire in a good sense is a characterization of us as physicians. And I'd like to thank my co-panelists, but especially I'd like to thank all those of you who have attended this webinar. If there are any questions, feel free to call upon us. You can certainly find how to reach us with the International Health Committee. And I'd like to thank the International Health Committee, especially Jada and Christina, for making that webinar possible. And with that, I wish you all a very good rest of the day or the evening, and hope to see you and hear from you again soon. Thank you very much.